There's a crisis in rural healthcare in the United States. Many of you know it, many of you don't. Between 1 and 2 rural hospitals close every month in the United States, leaving huge deserts, healthcare deserts, particularly in the center of our country. We've doubled down. We had 23 hospitals. Our 24th hospital we just opened is a virtual hospital. It provides teleservices. And we're now across 5 western states and into Alaska, helping rural communities serve in a much more sophisticated way. So you can be in a 14-bed hospital in the middle of nowhere that have a neonatologist from one of our quaternary centers helping to resuscitate a newborn baby. And what we're finding is hospitals that were on the cusp of closing are actually now economically vibrant. They're often the largest employer in their town. And now, does this make sense for us economically? Actually, no. But this is one of these things when we do well, like Clayton said, we pour it back into doing good whenever we can. And we think it's creating a self-sustaining model that drives more people towards this prepaid approach that's both rational economically and medically and also humane.
Javier, do you want to jump in here before I ask Paul a question about the inequality of healthcare and kind of what you've seen as you have started your organization?
Yeah, well, I think in terms of Mexico, and usually hospitals are driven by profit, so it's high-end complications. So in our case, when we look at type 2 diabetes, low income, it's definitely it's not something that you can get a lot of money from it.
Profit.
And a lot of profit. I agree that has to be a technology piece. When we came in and said, well, we have to serve these people with diabetes, and also I learned this when I was working in this indigenous community, it's not just about doing good. It has to be a piece of innovation. It has to be something that you have to change in order to make it happen.
Is technology a critical piece of that innovation for you?
Yeah, it absolutely, because so one is, well, we look at what's the 20% that makes the 80% of the impact. So typically when you go to a regular clinic and you have diabetes, the doctor will tell you 100 things to do. Well, we measure what's the impact of those 100 things to do, and you find out that 20 makes the 80% of the impact. So for low-income people, first you focus on this 20. Now, with the Swiss Agency for Development Corporations, we did a project. So they came and challenged us and said, I give you $250,000 if you increase your percentage of very low-income people. Typically, we had, of the very low income, we had 34%. So they came and said, if you raise it to 37%, you get this reward. So we said, okay, we have to increase this percentage. It's about retention as well, as acquisition and retention. But we cannot put more cost. So we went around the world and we came back with data analytics and behavioral science. So we said, we're going to nudge these people to do certain interventions. So now it's not only one treatment for all, it's based on archetypes and based on your income level. We do specific nudges to increase engagement. And we know that engagement means lower A1Cs, and means lower complications. We measure our impact on complications prevented. So this is how technology plus science come into the game.